My name is Frank Röhricht. I'm a consultant psychiatrist and I'm also a body psychotherapist per training, and I've been working as a consultant for East London Foundation Trust since 1987. Yes, that 1987 when I came to this country. I trained to become a psychiatrist in Germany, and I have a special interest in psychosomatic medicine and liaison psychiatry, and developed within Elft a specific somatoform disorder clinic. Following that, I've been trying to set up this particular care pathway, and I'm the lead investigator for the trial that we conducted with support of funding from the Health Foundation. The term medically unexplained symptoms has been used for a variety of conditions. It's a term that's been challenged really by service users and professionals, but what it does mean is that it captures a range of problems whereby patients present with a range of symptoms, physical symptoms, that cannot really be explained by any organic, if you want, pathology. And so this is causing a lot of distress to patients. It's causing functional disabilities, problems, because these patients very often go from doctor to doctor and don't really find a good solution to their problems. For that reason, it's quite costly. It's costly to patients because very often we find patients in a situation whereby they need a lot of support from health services, from social services, from families and carers in particular. It's costly to the society, it's costly to the healthcare system, and I think it's really important that we, from a provider side, begin to explore new ways of helping these patients, and that was kind of sort of the starting point for us to develop a new care pathway. So in doing so, the starting point for us was to, first of all, take into account the so-called psychosomatic nature of the problems. So this is not in the body, not in the mind. It's only to be understood as a problem that cuts across. So there is no difference to be made between body and mind when we try to explain these symptoms. And there are good reasons to believe, essentially, that our traditional way of looking at physical and mental health problems is anyway not right any longer, that we do need to have a more holistic view to these problems. I worked for about 2 years in a special service for psychosomatic medicine in Germany. That is a rather unique situation over there in Germany, where you have very special services looking after these patients. And one of the key, if you want, learning points for me at the time was that it's really important not to distinguish between mental and physical, and how, if various professions work together, these patients can get a better service. So another background for us to develop the model was that we, for a number of years, developed and provided actually a service for so-called somatoform disorder patients in Newham in East London. And when we looked at the service data, when we evaluated the clinical outcomes, we saw that it was helping patients, but it was difficult for patients to really get into the service because of our proximity, if you want, to mental health care services. So it was perceived as kind of reinforcing a message of, well, it's all in the mind, and patients didn't really accept this service. So we looked at how we can best move the service into primary care and to provide it as a one-stop shop service. And we took on board another important finding from partly of our own research, but partly also research conducted elsewhere. And that was that an approach that does combine the medical model, if you want, of looking at physical symptoms with approaches that enables patients to learn how to better cope with their symptoms. And that works predominantly through really concentrating on the level of complaints. That means really accepting that patients have a range of physical health concerns that need to be related to that it was much easier for patients to accept a more comprehensive package of care, a more holistic approach to their symptoms. So what we tried to do was to, in a way, address what could be described as a mismatch syndrome. So a mismatch between patients' beliefs and health professionals' beliefs, such as it's all in the mind, it's all in the body. We try to overcome that. In terms of language and terminology, we find a mismatch between, well, I'm in need, really, I need help, towards more like stigmatizing, if you want, labels used by professionals such as health anxiety. In therapy, we always find a difference between the professional perspective of, well, let's treat your pain, let's talk about your pain, whereas the patient would say, well, I'm actually in pain. I need to be recognized with the pain that I come along with. There's certainly a mismatch in terms of how much resources are already geared towards helping these patients, and how, unfortunately, the outcomes don't really match the expectations. And so in our one-stop shop service, we first of all tried to engage general practitioners, and not only the practitioners in terms of the doctors, but also the nurses and the receptionists, to achieve a better understanding, really, of the nature of the condition of these patients. So we were implementing this care pathway with training sessions. We spent a lot of time trying to find a way of how we can best engage patients in our discussions about their difficulties. And the bottom line was that we really wanted to invest time to understand how they are feeling about their symptoms, what kind of circumstances leads to a deterioration or an improvement of symptoms, in what way did it impact on their lives. And so we took a very open approach to understanding patients, but at the same time we also used a range of established measures, questionnaires, to fully investigate the range of physical and other complaints. We were interested in patients' quality of life, and we were interested in their satisfaction with treatment. And the treatment as such, so the interventions that we offered to patients, we're trying again to work with and through the body. So we, first of all, provided all the service users with a psychoeducation package with information. We started off running groups whereby we wanted to bring service users together and talk about the health condition, but that was not very well accepted. So we then moved towards providing the information, the necessary information about the conditions within the assessment sessions. And the two group-based interventions that we offered to patients were called mindfulness-based stress reduction and strategies for better living. And both of these approaches have a unique feature, which is they do actually work in a holistic sense. They do provide psychological support, they provide support about coping with symptoms, they provide ways of handling distress, bodily distress, as well as pain, in a rather comprehensive way.